Sure, sure.
Uh, Distinguished guests, honorable delegates, and esteemed participants, a very good afternoon and welcome you to this significant gathering on the occasion of commemoration of World Health Day. Today, we are here together to commemorate the health, reflect on our collective well-being, and reaffirm our commitment to healthier and more resilient world. So, good afternoon, and once again, and I am Arun Verma from the team Sipher. I, on behalf of the organizers, Sipher, Resource Center for Tobacco Control, PJMR, Chandigarh, and ECHO India, feel honored and privileged to extend a very warm welcome to our chief guest, Major General Professor Dr. Atul Kotwal, SMVSM. He is an executive director with the National Health System Resource Center, Ministry of Health and Family Welfare, Government of India. I also welcome our guest of honor, Dr. B.S. Garg, MD, PhD. He is a Secretary, Kasturba Health Society and Emeritus Professor of Community Medicine, Mahatma Gandhi Institute of Medical Sciences. I also extend a very warm welcome to our eminent speakers, Professor Dr. Rajkumar Goyal, Director, Vallabhbhai Patel Chest Institute, Delhi, and though he has not joined, Professor Dr. Sonu Goyal is a Director, Source Center for Tobacco, PJMR, Chandigarh. I also welcome Dr. Rakesh Gupta, President Sipher, Dr. Sanchika Gupta, likely to join very shortly, the project manager with ECO India, who is also a part of the organizers, and Mr. Rajiv Chaudhary, Program Coordinator for Resource Center Tobacco Control Department of Community Medicine, School of Public Health. As you know, that this year's theme for the World Health Day, which is falling on the 7th of April, and we are commemorating today. The theme is that my health, my right, which resonates deeply with the challenges we face today. As you know, the COVID-19 pandemic has exposed inequalities in access to the healthcare, social detriments to health, and the need for global solidarity. So as we navigate these complexities, let us remember that health is not a privilege, but a fundamental human right for everyone. So it is our collective responsibility. Health knows no boundaries. It transcends borders, cultures, and socio-economic status. It is a shared responsibility, one that rests not only with the government and healthcare systems, but also with each one of us, whether we are policymakers, healthcare professionals, educators, or community members, and our actions matters. So together we can create a fairer and healthier world. Our key priorities today are equity in healthcare, preventive measures, mental health, and environmental health. So as we embark on this World Health Day journey, let us remember that health is not just an absence of illness. It is a state of complete physical, mental, and social well-being. So together, let us build bridges, break barriers, and create a fairer, healthier world for generations to come. Thank you for being part of this vital webinar, and I once again welcome each and everyone to this significant gathering on the occasion of the commemoration of this World Health Day. Thank you. And now I would request and invite our director of the Sipher, Dr. Rakesh Gupta, to speak on about the World Health Day 2024. Over to Dr. Rakesh.
Thank you, Arunji. I welcome our chief guest of us. All know that we are commemorating World Health Day 2024. Around the world, the right to health of millions is increasingly coming under threat. Diseases and disasters loom large as cause of death and disability. Conflicts are devastating lives, causing death, pain, crisis, and taking away our right to breathe clean air, with indoor and outdoor air pollution claiming life every 5 seconds. The WHO Council for Economics of Health for All has found that at least 140 countries, they recognize health as a human right in their constitution. Yet, countries are not passing and putting into practice laws to ensure their populations are entitled to access health services. This underpins the fact that about half of the world population were not fully covered by the essential services. To address these types of challenges, the theme for the World Health Day is My Health, My Right. This year's theme was chosen to champion the right of everyone, everywhere to have access to quality health services, education, and information, as well as safe drinking water, clean air, good nutrition, quality housing, decent working and environmental conditions, and freedom from discrimination. So I request Arunji to please proceed with the proceedings. Thank you.
Thank you, Dr. KG. I can see that Professor Sonu Goyal has joined. So once again, I welcome Dr. Sonu Goyal, who is a director with RC Resource Center for Tobacco Control, as well as he is a professor in the Department of Culinary Medicine, School of Public Health, PJMAR. Welcome, Dr. Sonu Goyal. And Dr. Sonu, as you know, he is a recipient of various awards, including Young Researcher Award by the IAPSM Ford Foundation, Harcharan Singh Oration Award, Vasudeva Oration Award, and many more to his credit. He is a vice chair of the Tobacco Control Section and leading Empower Resource Group of the Union, adjunct associate of clinical professor in the School of Medicine, Faculty of Education and Health Sciences, University of Limerick, Ireland. He is an honorary professor in the Faculty of Human and Health Sciences at Swansea University, United Kingdom. Dr. Sonu will be speaking, Is Health Your Right? So over to Dr. Sonu Goyal.
So thank you, Arunji. So maybe, yes, I'm giving. So first of all, it's my profound pleasure to speak in front of two luminaries who are here, Dr. B.S. Garg and Dr. Atul Kotwal. So I think they are the people who have been working for public health for decades altogether. And it's really a pleasure for me to speak in front of them. And I'm really happy that Sipher has organized this webinar well in time, even before the World Health Day. And a very important topic this time on World Health Day is health your right? So I thought to choose this topic to clear the misconceptions among the public health specialists and others that whether health is regarded as our right or not. So in this next 8 to 10 minutes, I'll be just briefing about this particular topic. So everybody knows here who are in public health that the definition of health we always used to learn from Park. Health is a complete physical, social, mental well-being and not merely an absence of disease or infirmity. So this is a WHO definition long back. And you can see on the right-hand side of the slide that health is not only developed, it is basically an amalgamation of what is happening in our body, what is happening around our body, like our social systems, our physical environment, our work environment. So health is an amalgamation of all these things, our physical environment. So they play a very important role to diseases and also the social and mental well-being. So now coming to the topic that whether health is regarded as a human right or not. So let us try to understand, even we can debate later on that whether health is right or not. So if we see the global perspective, so first we see the global perspective. So in a WHO constitution, and this is a document which I retrieved, the 1966 International Covenant on Economic, Social and Cultural Rights. So in that document, WHO document, it is clearly stated that health is universally recognized as a fundamental human right. So that is a clear statement by WHO in a document which was published almost 70 years back. And then in another document of 1948, Universal Declaration of Human Rights, this is also a very important document, which also states that health is a part of the right to adequate standards of living. So here they have not specifically put health as a human right, but they have put that health is a part of the right to the adequate standard of living. So we all have in our country a right to have an adequate standard of living. So then what UN say, what United Nations says, and WHO again says that a right to health is an inclusive right. So right to health extends further than access to health care and infrastructure. So it says that it's not only our healthcare and infrastructure which is our right, but whatever things are impacting our health. So it is a very broad thing which they have said. Whatever is impacting our health, whether it is our outside environment, whether it is our work environment. So all these things are our right. So it's an inclusive definition which UN and WHO has put. They have not categorically said about a particular thing, but they have broadened the thing and kept it the member states or the countries to put it in the right way. Other states that right to health is freedom. That is right to be free from non-consensual. So again, it says that everybody should be given the treatment, the medical treatment at the right time. So that is again our right. And right to health also contains various entitlements. That is right access to essential medicines. So that is a right according to WHO. Right to prevention, access to basic health services, treatment and control of diseases. So not only WHO has said that right to health is extending further than just healthcare institution and infrastructure, but it also says that everybody should be provided essential medicine, essential care, basic services, basic treatment and control of diseases. Now let us talk about Indian Constitution. This is the preamble of an Indian Constitution. And I think everybody here might have seen this, this document. So I'll just come to the specific part where they have defined health per se. So the directive principle of state policy. So first of all, before that, before directive principle, I will just like to tell you that Article 21, I think everybody knows about Article 21. Article 21 is right to life and liberty. So we have right to life and liberty, and right to it. It categorically said it has not said about specifically about right to health, but right to health is inherent to right to life. Everybody knows that it's a part. Right to life is an overall ambit, and right to health is a part of right to life. So this means indirectly our constitution is saying that right to health is should be there. And now there are various articles of the constitution like article 38, 39, 42, 43 and 47. So these are specific articles which put obligation to the states, which put obligation on the state to ensure realization of right to health. Now, this is again a very important thing that these articles 38, 39, 42, 43 and 47, they put the responsibility or onus on the state to ensure a proper health. And again, as we have said that this directive principle of state policy, health is a state matter. This is put forward in Article 47. So if we see the concurrent responsibility, so there are various responsibilities. I think everybody knows there are some responsibilities which are bestowed to the states, some responsibility which are bestowed to the center, and there are some responsibility which are joint responsibility, state as well as central. Now, if health is state matter, why central government is providing various services, the National Health Mission and all those things? So is it that the central government is not providing, it should not provide the health? No. So they have specifically said that central government, that Central Council of Health and Family Welfare, enables consideration and recommendation of broad lines of policies in regard to matters concerning health and family welfare. So this means that central body is an advisory body, primarily an advisory body. Funding, primarily a state, provision of health, primarily a state, the advisory body advice should be given from the central. And of course, some of the financial thing can also be given by the central. So Constitution doesn't, as I told, Constitution doesn't explicitly mention right to health, but they have mentioned right to life and liberty, and right to health is inherent to right to life. Now, I think these are the challenges which India is facing. This is just a snapshot of very small, a micro level, I think, challenges. Despite a huge impetus which has been provided by National Health Mission, we still faces challenges that there is an inequitable distribution of doctors, resources between rural and urban, and we are now reaching a doctors patient population ratio, which is what is desired by WHO now. So we have almost now in the verge of reaching that particular thing, and we have a dual burden of disease, and still we are spending very less on healthcare as compared to many other countries. Like we are spending around 2.1% of GDP in financial year 2023. And if we see the lower overall global average in low and middle income countries, I'm not talking. So there are various changes, although there are various documents which are put forward as a part of national health policy. So I have just put, because there are very huge documents. So these are various priorities. If you see in 1983, the first time the health policy was formed, the comprehensive primary healthcare services was part of it. We used to read when we were in graduates that equitable access to healthcare, and even the traditional medicine was part then in 1983. And they also encourages community participation. But when we move to 2002, so again, they have further strengthened primary healthcare services, but there the concept of universal access to healthcare. So that, although it was part of it 1983, but in 2002, they have categorically put that. And the main important component in 2002 was public-private partnership. Initially, all the health, basically the government thought the health should be provided only by public, primarily by the public hospital, but then we realized that we need to develop various models of public-private partnership. And the increased public spending on healthcare, of course, was part of the 2002 document. But in 2017, the main important component which is there is the technology, the leveraging technology. And we have seen that mental health has been an integral component of 2017. And strengthening healthcare, human resource, and infrastructure were, of course, part. So there has been a slight change in the health policies, the priorities have been changing. Again, we know that we have to see that priorities, we have various schemes like Ayushman Bharat and Pradhan Mantri Jan Arogya Yojana. And our country is the largest country which is providing this beneficiaries, the cashless treatment up to 5 lakh rupees free of cost. And so all these things, Rashtriya
Dr. Sono, I may just point out, please conclude. Thank you.
Yes, this is the last slide, sir.
Okay.
So what now I have told that in the preamble, the health, they have told in the constitution that the state should be responsible primarily for health. So has any state done something for right to health? So in India, recently the Rajasthan Assembly passed a right to health bill. So that was the one bill which was there, and there were many components of that bill. but that bill could not pass through the parliament. So they introduced the bill, but that bill could not be passed. So you have seen that in this just recently happened in 2023, March 2023. And the main components was the right to obtain pertinent information regarding health, investigation, free OPD services, IPD consultation, free drugs, free diagnostic, and all those things were there. And access to emergency treatment without prepayment of requisite fee and charges. So the ultimate, these are some of the references if somebody wants. This is a case study of health as a human right for Indian tribal community. So if somebody wants to read about this, so please feel free to read that from the link. But ultimately, the main outline of this presentation is, although our constitution says that health is a right, is a human right, maybe not directly, but indirectly, we need to do a lot of efforts in various states where we are living so that right to health sees the light someday. Thank you very much.
Thank you. Thank you, Dr. Sonu. So we'll have concluding remarks at the end, and Rajiv will be presenting concluding remarks.
So thank you, Dr. Sonu. A very nice presentation of the topic is right your health. Sharing with our eminent participants. It's an impressive participation, 113. It's a record participation. And for sharing with them the global and the national perspective on the right to health, the aspects of health in the Indian Constitution and the legal framework in India on this subject. Also the state and social responsibility in this regard and the government initiatives and programs. Thank you very much. Now, our next speaker is
Varmaji, can we have a snapshot? If all,
please, I request everyone to switch on the video so that we can shot a snap. Everyone requested to please switch on the video.
So Rajiv, can you take a snapshot?
Sanchika ji aa gaye hain.
So Sanchika can take a snapshot, sir.
Yes, sir, will take.
So we can, I think, continue if it is done. Okay, thank you.
Okay, thank you so much. So our next speaker is Dr. Rajkumar, who is the director Vallabh Patel Chest Institute. He will be speaking on the topic why tobacco cessation is important to manage TB and NCDs. Dr. Rajkumar, professor, is a renowned pulmonary physician with nearly 3 decades of illustrious teaching experience to the students in the area of DM, MD, DT, DC, and pulmonary medicine and PhD. He has contributed vastly to the research activities related to the chest and allied diseases with proven excellence in quality patient care. Professor Kumar has a vast administrative experience as well. So presently, Professor Kumar is working as a director Vallabh Patel Chest Institute, known as BPCI, Delhi, a premier research institute funded by the Ministry of Health and Family Welfare, Government of India, and maintained by the University of Delhi. Professor Kumar is an officer in charge of the Vishwanath Chest Hospital and also the head of the National Center of Respiratory Allergy, Asthma and Immunology. He is a head of the Department of Pulmonary Medicine, Faculty of Medical Sciences, University of Delhi. He also headed the Department of Respiratory Allergy and Applied Immunology since 2008 at BPCI. Due to his vast clinical experience and excellent academic record, he was also selected as the director AIMS Patna in 2016. Awards and recognitions. Professor Rajkumar has been a recipient of various national and international awards and honors. Shiksha Gaurav Puruskar in 2014 by the Center of Education Growth and Research, New Delhi. Excellence Award in 2012 for incredible contribution in the field of education by Mahatma Gandhi University, Meghalaya. David A. and Julie Stevens Scholar Award for contribution ABPA in 2006 in Greece. Senior Scientist Award in 1990. Rashtriya Gaurav Samman in 1998, Delhi. Gaurav in 1997 by Delhi government for outstanding performance, recoverable contribution and distribution services to the IMA East Delhi branch. A really eminent doctor. So over to Dr. Rajkumaji for the topic why tobacco cessation is important to manage TB and cities.
Okay, thank you. Thank you very much, sir, for introduction. And at the outset, I must thank Dr. Rakesh Gupta ji, President of Sipher, for organizing such beautiful program and rather giving me the opportunity to talk about the tobacco cessation. Is tobacco cessation important to manage TB and NCD? So I'll just share my slides. You have to enable to share the slide.
Sanchika ji, can you do it?
I'll try, sir.
Okay.
It's done.
Okay, I think the slides are visible.
Yeah,
Slides
yeah.
are- yeah.
Yes, these are visible.
Okay, so another maybe 12 to 15 minutes, I am going to talk about why tobacco cessation is important to manage tuberculosis and non-communicable diseases. Greetings from Vallabhbhai Patel Chase Institute. And we know that we are basically having the dual epidemic. One is the pulmonary tuberculosis and the tobacco cessation. And this is the major global public health problem. And we are facing not a single, but a dual epidemic. And TB is the leading cause of death from infectious diseases worldwide, causes millions of deaths every year, more in the low and the income group countries. And smoking is basically causing significant morbidity in the mortality of the tuberculosis and so on. If you see, basically, the smoking is a risk factor for tuberculosis, and this has been documented many times. But now there are many established publications are there, which is now established. There is a link between smoking and the tuberculosis, and it interferes with the multiple biological mechanisms which are very important, like the defense against the initial infection with tuberculosis and subsequently development of the tubercular disease. It impairs the clearance of the secretion of the airway, and of course there are many immunological mechanisms which is there, where the smoking is going to interfere, which causes basically disease to proliferate or the disease to have a more severity. So smoking approximately doubles the risk of the tuberculosis and disease and the TB deaths. And the smoking is a significant risk factor for tuberculosis, with an increased likelihood of the infection, death, relapse after treatment, and greater clinical severity with the longer delay in the TB diagnosis and the treatment. And if you see, basically, a lot of data suggests that not only the active smoking, but the passive smoking also causes TB infection, progression in the pulmonary disease, severity of the disease, mortality, and so on. So if the person is a smoker, he has a twice risk of both tuberculosis infection and the active disease. And basically, it causes delay in the sputum smear conversion and responsible for more severe form of the disease. And one of the very good study which has been done in our country, Gajalakshmi et al., found that the smokers were 4 times more likely to die of the tuberculosis. And after this study, a lot of more study has come where it shows there is a direct link between the smoking and the tuberculosis. So it is very important that we must do the smoking cessation in case of the tuberculosis patient and so on. These are some of the studies which shows there is a link between the active smoking and the passive smoking also. And these studies highlights basically the people who are active smokers are around 2 to 3 times basically prone to develop tuberculosis, and same is the case of the passive smoking and so on. So what is the mechanism of the effect of the smoking on the tuberculosis patients? A smoker, basically, when he is smoking, so there is a loss of the defense mechanism, and in the form of the decrease of the mucociliary clearance, impaired phagocyte function of the alveolar macrophages and impaired activity of the natural killer cells. And there are many enzymes, basically induction is there, where there is a problem in case of the management, like the rifampicin level in the smokers and so on. So if we see the smokers adversely affect the treatment response, outcome, relapse, and the tuberculosis. And this study shows that smoking is associated with the more severe form of the disease, lung cavitation. And of course, if you compare current and the excess smokers, then the sputum smear and the culture were significantly more likely to remain positive after 2 months of the treatment. And both categories of the smokers were significantly less likely to achieve cure or the treatment completion within 2 years and so on. And it has been shown that among the successful treatment completes, there is a higher relapse rate in the ex-smoker and the current smoker. So relapse rate also is higher in case of the smokers and so on. So smokers adversely affects the baseline disease severity, bacteriological response, and the treatment outcome, and the relapse in the tuberculosis and so on. So smoking cessation is likely to reduce the relapse and the secondary transmission of the disease and so on. The smoking also affects on the immune system of the lung, and then there is a dose response relationship. If you are a smoker, it depends upon the number of the bidi or the cigarettes the person is smoking, and the duration of the smoking also. These are also two factors which contributes towards the disease of the tuberculosis and so on. This slide shows, basically, I will not go into detail about that, but whatever I have told. So the effect of the cigarette smoke exposure on the innate and the adaptive immunity that may influence the control of the Mycobacterium tuberculosis infection. So you can see, basically, there are many changes which occurs when the person is smoking. So the question comes, if we are able to stop smoking or tobacco cessation is given to these, does it really going to help? Yes, the answer is yes. The smokers with the tuberculosis are receptive to advice of the quit, but often they start smoking. And in case of the DOTS also, if you are giving a DOTS treatment and everything, combination with the advice is going to help. And smoking cessation with TB treatment significantly lowers the rate of the treatment default failure in patients and improve the quality of life. And it has been shown that the smoking is associated with the ninefold greater risk of the health associated with the TB, which drops to as much as 65% upon smoking cessation. So the risk also reduces drastically. So the smoking cessation improves the course of the disease, the observation of the treatment, and have an impact on the incidence of the disease. Hence, smokers with the TB to quit smoking is required. One of the study, it has been clearly shown that if a person quits, and they have compared, they have seen the quitting effect on the health outcome during the treatment for the tuberculosis, and it has been shown compared with the non-quitters, those who quit has a better TB cure plus the treatment completion rate, lower TB relapse rate, and among the quitters, higher sputum conversion rate at week 9, and lower mean TB clinical score, and of course, slightly better quality of life at the 6 month were observed in the quitters and so on. And this slide also shows basically the outcome when the person has quitted, or they have compared with the never smoker or ever a smoker, basically. So if a person is smoking, the person is going to be not getting the relief as it should be getting. So the second part of my talk is importance of smoking cessation in the non-communicable diseases. And if you see, basically, the non-communicable diseases kills around 41 million people each year, equivalent to 74% of the all the deaths. Each year, 17 million people die of the non-communicable diseases at the age of 70 years, and 86% of the premature deaths occurs in the low and the middle income group. Cardiovascular disease is, I think, the most important among all, and and these four cardiovascular diseases, cancers, COPD, and the diabetes accounts for 80% basically of all the deaths in case of the NCD. And so tobacco use and the physical activities, harmful effect of the alcohol, then unhealthy diet and the air pollution all increases the risk of the dying the patient from the NCD. If you see the risk on the cardiovascular system by the smoking, heart attack, and there are many like hypertension also increases. Then the heart attack is more than the twice in the compared to the non-smokers. And one of the factor which contributes is the smoking in all kind of the cardiovascular diseases. Same is the case for the COPD. There is a directly link between the COPD and the smoking. Here I just wanted to clarify that there is no difference between the cigarette smoking and the BD smoking, and nowadays it has been seen that rather the BD smoking is much more harmful than the cigarette smoking. There is a direct link between the diabetes and the smoking. So the people who are the smoker, the chances of uncontrolled diabetic basically is much more. And of the people with the diabetic who needs amputation, 95% are the smokers. And if you consider the cardiovascular disease along with them, then they have a 14 times basically more severity of the disease compared to the individual ones. There is a direct link between the cigarette smoking and the stroke and the hemorrhage. A simple rhinitis is also linked with the smokers, and it has been seen that with the BD smoking, the rhinitis is much more compared to the cigarette smoking and so on. Coming to the smoking and the lung diseases, means I have tried to enumerate all the lung diseases. So all the lung diseases are directly or indirectly linked with the smoking. Let it be the COPD, then the pneumothorax, bronchial asthma, cancer, then tuberculosis, then infection, then idiopathic pulmonary fibrosis, and so on. There is a direct link between the smoking and the cancer. Apart from the lung cancer, the other cancers like the larynx, pharynx, esophagus, kidney, they are also directly affected. And this slide shows basically how the cancer occurs because of the smoking and so on. This slide shows how the passive smoking also is directly linked with the cancer. So not only the active smoking, but the passive smoking is also going to give the harm. In a nutshell, if you see a smoker, directly or indirectly, every part of the body is affected by the smoking and so on. So every part from hair to the toes, nails of the toes, all are affected by the harmful effect of the tobacco. So coming to the smoking cessation. So after smoking cessation, the cumulative death risk of the lung cancer decreases. The early cigarette smoking stops the greater the decline in the lung cancer mortality, and it is better to stop smoking at the early age or quitting at the early age, which will be beneficial basically for all the cardiovascular diseases and even the lung cancer and so on. So if you see basically effect of the smoking reduction or in case of the cancer, so it is also advisable whenever there is a cancer to the patient already caused by the smoking, after diagnosis of the cancer, is smoking cessation is still important? Yes, very important. Continuous smoking after the cancer diagnosis has been strongly correlated with the poor outcome, and the smoking cessation after diagnosis improves response to the therapy. Hence, its importance to promote smoking cessation after the cancer diagnosis is very important. Same is the case of the cardiovascular diseases. The cardiovascular diseases lowers the risk of the cardiovascular diseases after 5 years of the cessation, and same is the case for the diabetes. If you see the COPD patients, basically, whenever you are smoking, there is a drop of the FVC because of the smoking. But whenever you stop smoking at any moment, you are going to be benefited and your lung function is going to improve. In nutshell, if you see the health benefit of the quitting, it starts from 20 minutes and the risk of the heart attack begins to decrease in 24 hours. Then the taste and the smell also improves. Then improvement in the lung function, circulation 2 weeks, lung improves the capacity basically. Then the risk of the heart diseases is reduced by 50% at 1 year. Risk of the stroke is reduced by reduced in 5 years, and the risk of the lung cancer is reduced by half in 10 years, and the risk of the heart disease is similar to a person who has never smoked. So the day you quit, basically all the diseases are going to be taken care, and it starts improvement and so on. So in this slide you can see basically harmful effect of the smoking, and if you quit, these are the benefits which have been enumerated are of the quitting of the smoking. And there are many activities which has been launched by the government of India. One of the very important is the M cessation, basically, where you have to just send a message, and the number is 229011701. And after that, the people we are going to take care with the text messages and so on. Government of India has started the National Tobacco Quit Line Services in 2016, and it's a proactive, basically, tobacco cessation services, where you can dial to them, and they will be available from 8 o'clock morning to 8 o'clock evening. And they will be considering you for the cessation and everything, and they will be giving you the proactive call. They will set a quit date. They will give a call at pre-quit date, quit date, post-quit date, and after 1 month, 3 months, 6 months, and 9 months, basically. And the number is 1800112356. Now, this has a satellite centers in Tata Memorial at Mumbai, Nimhans in Bangalore, and Guwahati Regional Cancer Institute. And it is functioning from Tuesday to Sunday, from 8 o'clock morning to 8 o'clock evening in 15 regional languages. With that, I thank and appreciate for kind listening. Thank you so much.
Thank you, Dr. Rajkumarji, for a very nice and detailed presentation on a very relevant and important topic of the day, that is importance of tobacco cessation to manage the tuberculosis and NCDs, which is a main cause of the deaths these days because of the smoking. So now I'll be inviting our guest of honor, Dr. B.S. Garg, and I will also invite Dr. Rakesh Gupta to introduce our guest of honor. Dr. Rakesh Gupta.
Sure. So we have with us Dr. B.S. Garg, who is Secretary, Kasturba Health Society. He is an emeritus professor of and Secretary, Kasturba Health Society, working in Department of Community Medicine, Mahatma Gandhi Institute of Medical Sciences. He has been president of IAPSM 2002, president of VHAI from 2009 to 13. Dr. Garg is a recipient of Dhanvantri and Harcharan Singh Oration. He was awarded Best Teacher by Maharashtra University of Health Sciences, Nasik in 2006, and Commonwealth Medical Fellowship at Liverpool School of Tropical Medicine. So you are welcome, sir. So you may please give your address. Thank you.
Thank you. Thank you, Dr. Rakesh Gupta, for a kind word. So at the outset, I would like to thank the Sipher ECO for inviting me for this important event. Many things have been covered. The theme is my health, my right. I feel that we must add one more, two more words after that, my responsibility also. The right can only be exercised once you discharge your responsibility. Otherwise, it's not possible otherwise. Well, I would like to speak on 2-3 aspects related to health. The one is accessibility, another is equity, and third is quality. Gandhi said that in the end of the day, you ask a question to yourself, whether your work has helped the poorest poor or not. In case answer is yes, you should feel happy, have a nice sleep. And in case answer is no, it gives you a reminder that you have to work hard to help the poorest poor. So Gandhi said this thing nearly about 100 years back, but today also this is valid. So you see 2002 policy, which Dr. Sonu referred just now, or 2017, in both, it has been accepted directly or indirectly. The access to primary health care is not beyond 30%. So what can be done? And we have to introspect, we have to evaluate and address all such issues. Say today we feel very happy that our IMR has come down, our MMR has come down. But when you start categorizing, stratifying them into the 5 quadrants, especially the poor and very poor, immediately you get a message that improvement in that segment is not up to that level. So that's an indirect indicator. Accessibility to healthcare, especially in rural area, tribal area, urban slum, is a big issue. Otherwise, say we have multiplicity of availability of healthcare, but in these 3 areas, still is a big issue. At Sevagram, we did a little experiment regarding this, and we tried to delegate the responsibility to people themselves. Over the last 25 years, we did this experiment, and in 27 villages, we successfully running the village primary health care with the help of the community. Rather, it's owned by the community. We just provide them technical support. Initially, we started with the basic primary health care, but now we have added so many other components, right, of RMNCH plus, non-communicable disease. Now they are taking care of growth monitoring also. They are taking care of screening for anemia, diabetes, and so on. So it's possible in case you are determined. No, but accessibility, it has a link with the equity also. See, in India, what happens, the disparity lies in the availability as well as the utilization of healthcare in almost all the segment, whether it's urban, rural, or urban slum or tribal. So we have to find out the cause for that. Why is happening? See, we have this Ayushman Bharat, we have this health and wellness centers, we have ASHA, but in spite of that, the poor person, the woman, the say people in the slums, they are not getting their due, which or for which they deserve. Now, another question is of quality. See, wherever say we are providing services, say, take example of antenatal care. We are very proud that yes, we have achieved very good antenatal care coverage in this country. But when starting seeing the quality, then we come to know that yes, we have to do a lot. So there are such many such issues, and for that again, the quality. Usually, what we do that we see the quality at the input, but I think the quality of output is more important, like client satisfaction or exit interviews. Again, in corporate sector, we see that high quality service is there, but always remember health encompass. See, when we talk of high quality services, say we compromise with the cost effectiveness. Similarly, when we talk of equity, then also say service may be high quality, but it may not be access to the poorest poor. So all these issues are there. So when we celebrate this WHO Day today for My Right, My Health, please remember that lot has to be done, and we have to educate the people also, so that they discharge their responsibility, start discharging the responsibilities. The NCD, what is that? Is basically a lifestyle disorder. In case we take care of our nutrition, physical activity, and so on, we can take care of it. So, and remember, the solution is not only with the modern system of medicine. We have to provide integrated system of medicine. I close my remark with the Gandhiji's say comment which he gave when he opened the Tibia College in Delhi in 1925. He said, "I'm very happy in opening this college because I see here that they are combining the allopathy with the Indian system of medicine. I think which is the need of the hour, because this our own Indian system of medicine is better acceptable, but we have to do some research. We have to say comprehensively combine it with the modern system of medicine or allopathic system of medicine. And I'm sure that in case we go with that, we would be able to fulfill the WHO theme of my say health, my right. And but lastly, I also request everybody that please, time has come that we have to link this health with the development. And so means in case we enjoy good health, we will contribute development to our family, our community, our nation. Thank you very much.
So thank you,
you.
Dr. Garg. And I'm thankful to Dr. Sonu also for introducing me and asking me to call you as a guest of honor. So thanks a lot. And you shared your personal experience in Sevagram, which extends to almost 3 decades. And you told us that you have included primary care initially, and then you included RMNCH, NCDs, growth monitoring, and screening, etc. So we need to have accessibility, equity, and quality of the output. That is more important. And you said it right that in corporates, you can have quality of services, but they are not really cost effective. So thanks a lot, sir. So I'll like to call Dr. Kotwal. So he's Major General Professor Atul Kotwal, and he's an Executive Director, National Health System Resource Center, MHFW, Government of India. Major General Kotwal is a medical professional, public health researcher, administrator, educator, mentor, and a teacher with significant contributions in the field of public health for more than 37 years. His area of expertise includes health systems planning and implementation of the healthcare policies, primary healthcare, urban health, epidemiology, and interdisciplinary research. Dr. Kotwal has a diverse experience, including serving in the armed forces across all the levels of medical corps. Incidentally, we had AMC Day yesterday, and I greeted him for that.
Thank you.
And he has been an advisor for public health in Botswana, Africa, and in providing technical support to Government of India as OSD Public Health in erstwhile Planning Commission. In his tenure as OSD Public Health in Planning Commission, he was involved in planning and finalizing the 11th five-year plan, reviewing NRHM and conceptualizing urban health. So Dr. Kotwal has received numerous awards for his contribution to the armed forces and towards his professional and research achievements. He has also been awarded the prestigious Dr. J. Parakh Oration by the Indian Public Health Association. With more than 140 publications in index journals, he has contributed to the evidence generation, knowledge sharing through designing and undertaking research and providing academic support in the field of public health. So thank you, Dr. Kotwal, for joining, and over to you, sir.
Thank you, Dr. Rakesh Gupta, for the introduction, and thanks to you and your entire Sipher team, and also the Resource Center for Tobacco Control, PGI, for giving me this honor and for inviting me for this important webinar on commemorating the World Health Day of 2024. A very interesting topic. But before that, I think I must pay my respect and regard to Dr. B.S. Garg, sir, one of the senior most luminaries in our field. Thank you, sir, for sharing your views, and it's always a pleasure to listen to you and the grounded reality which you share with all of us whenever we discuss anything with you. And I would like to thank Dr. Sonu Goyal for putting it in context, and also Dr. Rajkumar, who touched upon the important issue, which I'll get into my few words, which I'm going to speak over the next 7-8 minutes. So important issue right now is health as a fundamental right? And also, when we talk of right to health, we talk of right to health or right to health care. We all should be very, very clear in these nuances. Our constitution, Dr. Sonu Goyal very rightly mentioned, in that there is no provision of health as a fundamental right. As we all know, there are various challenges in ensuring that. And as very aptly mentioned by Dr. Garg said, that what about the individual actions towards healthy behavior and health-seeking behavior? Could this be a one-way street only, that we demand for the health as a right and we don't talk about our responsibility? And additionally, Dr. Rajkumar presented about the risk of increased morbidity and mortality due to tobacco consumption. And I think that's in all, anyone who's done public health or linked with public health, the first example, the tobacco and tobacco and morbidity mortality from the Doll and Hill study, which we all study in detail and all regarding the epidemiology as such. So thus, when we talk about rights-based approach for health, I think we should take a balanced approach rather than expecting everything from system without similar actions from our own. And the another aspect is legislation. As Rajasthan did that and passed the act in March 2023, it may be easy to legislate, but what about the public health system, the availability of the quality services? So it does be prudent to first strengthen our own healthcare system and then discuss its issues. However, be that as it may, health as a right has been implied in various provisions and of the Constitution. And in fact, the Constitution not only limits itself to that, it also talks about the social determinants of health also, and also the Supreme Court judgments also, and our actions now which we are taking based on the National Policy 2017 and also our efforts towards achieving the SDGs are steps towards the right-based approach only. The Article 21 talks about this, the right to health to be inseparable part of life in India. The directive principles also, like Article 38, promotes welfare of its people. 39 protects their health and strength from abuse. 42 is about just and humane conditions. 46 talks about the improvement of public health, and 47 talks about nutritional levels, that social determinants of health which I was mentioning earlier, and also 23 about prohibiting human trafficking and child labor. 21A is also, this thing talks about free and compulsory education for all children in the age group of 6 to 14 years as a fundamental right. And there have been international covenants, WHO declarations and all, Dr. Sonu Goyal provided it in detail, so I'm not touching upon those. But in summary, if you see, in brief, if you see, the move of the government of India in coordination with all the states towards universal health coverage, and I'm not providing definition of UHC, but if you see the important words of the definition are affordability, the out-of-pocket expenditure and preventing catastrophic expenditure, availability of services which are accessible, acceptable by community, that means the community involvement, and high quality services with equity in mind. That is what is universal health coverage, and that is what will help us in the rights-based approach also. Because if the services are not there, what is the use of a piece of legislation providing the right to health as such? And national health policy has committed itself towards universal health coverage, and that's why there's an additional budget of 30% also towards high focus districts, aspirational districts, tribal areas under NHM program. And the aim now is to strengthen comprehensive primary health care. That's to provide preventive, promotive, curative, rehabilitative, and palliative services. Dr. Garg has also mentioned about screenings and all of the NCDs, but that are now being linked with assured linkages with secondary and tertiary care and efforts towards strengthening secondary care through the centrally sponsored schemes. There are tremendous efforts to strengthen tertiary care through the centrally sponsored schemes where the funding is totally by the central government of India, 100% through central government of India. And there's a schemes like free drugs and free diagnostics launched in 2016 to 2015, 2016, with a list of medicines at each level of public health facility. But the challenges are in the implementation of all these, how to ensure that they are available. A large number of facilities, like now the sub-centers and PHCs erstwhile have been converted into Ayushman Arogya Mandirs. We have more than 170,000 Ayushman Arogya Mandirs functional right now. We have an additional HR, the community health officer, which was never there at the sub-health center level earlier. We have this expanded package of services. All 12 packages of services is not only the reproductive, maternal, neonatal, child health, adolescent care, and nutrition part earlier, which was earlier erstwhile health and wellness PHCs and sub-centers. We are now looking at providing comprehensive services, including non-communicable diseases, communicable diseases, emergency and trauma care, eye and ENT care, oral care, palliative and elderly care, mental, neurological, and substance abuse care. These are being implemented. There are more than 60% of these 1,70,000 where all these services, the trainings have taken place. The drugs are available of more than 80% of the list, and the further rest 40% also efforts are done. Large number of screenings have been done. It's in crores, 69 crore for hypertension. The diabetes is more than 56 crores. Oral cancer also more than 88 crore, and same for cervical and breast. Cervical cancer more than 11 crore, breast cancer more than 17 crore. And a lot of these which were positive in screening were then diagnosed. And of course, that is where more strengthening is required now, that anyone who's screened is sent for diagnostic testing, and in case of confirmation is provided treatment. That's where the linkages with the secondary care, and that Dr. Sonu Goyal mentioned about the PMJ. At least 60 crore 60 crore population of the country out of 140 plus is assured of 5 lakh per annum package, and we are now recommending to the government to increase that amount. But again is the financial availability also which is there. Then when I talked about the acceptability by the public, so instead of the Rohi Kalyan Samitis which used to be earlier there in Ayushman Arogya Mandir, Jan Arogya Samitis are being constituted. They have been constituted with regular meetings now being ensured, untied funds being given to them, and social accountability part coming in, where they become part of the health system as such. And it's not only the providing services of these curative and rehab and investigative and rehabilitative. It is also moving beyond illness to wellness, and so that's where the wellness activities and yoga and even the meditation, these cyclothon, walkathons, so and observation of health calendar days at these Ayushman Arogya Mandirs, which will further strengthen the community linkages as such. And the infrastructure was always, out of see the health budget over the years, infrastructure proportion was much lesser than the current health expenditure as such. So now the total health expenditure out of that, almost 18-19% has become certainly infrastructure, which will be there for a few years, because all that infra which we always bemoaned the fact that our buildings were not good, infra was not available for consultation, for waiting areas, for doctors to sit, for the nursing for the work areas. Now the funding is there through PM Abhim and 15th Finance Commission tied grants, which have been there for the first time in the history of independent India for the rural local bodies and urban local bodies and rural Panchayati Raj institutions. The digital is also being leveraged with teleconsultations, with the Aadhaar IDs now coming up, which will enable us longitudinal record follow-up as such, which will improve the further continuum of care, which is required now for the non-communicable disease, for upward referral and downward referral and follow-up at regular intervals. So that's where Ayushman Bharat digital mission is helping in strengthening of the entire health system. To look at, when you talk of equity, although these are being strengthened, but certain efforts are required to address few of the problems immediately. That's why National Sickle Cell Anemia Elimination Mission to cover 17 states with the higher tribal area, with the targets for screening, and also financing is there for the point of care tests, and also strengthening the equipment in district hospital for confirmation and looking at all the other hemoglobinopathies also. And similarly, PM Janman is there now for PVTG, but particularly vulnerable tribal groups, with dedicated funding for that. So if you see all the aspects of universal health coverage are being addressed. What is taking time now is the implementation. That's where we need to strengthen more, and that's where all public health specialists have to come together. The medical colleges have to work with the health systems as such to ensure that the funds are effectively and efficiently utilized, and the capacity building is done. Supply chain management is strengthened to ensure that those drugs and diagnostics are available, which is as per the essential drug list, essential diagnostics list. And I'll share with you the heartening thing is that as per national accounts estimates, which NSSRC prepares is one of our job, in 2013-14 financial year, out of total health expenditure, 64% was out-of-pocket expenditure. So coming off the pocket of you and me. In 2019-20, it is reduced to 47%. We have the national accounts of 22-23 also, 21-22 also, but they have not been approved as yet. But I'm just sharing with you, it is further reduced quite a lot from this 47%. So that's when we are expanding our infrastructure, improving our infrastructure, expanding the availability of drugs, diagnostics, ambulance services numbers, and improving the outpatient with ECRP 1 and 2 has introduced, huge number of beds at the ICUs, HDUs, and also routine care that is showing significant reduction in out-of-pocket expenditure. And funding pattern, if you know, as Dr. Sonu mentioned, so I would just like to add on to that. In centrally sponsored schemes like NHM, it is 60% from the center, 40% by the state. In the smaller states and northeast and hilly states, it is 90% by the center and 10% by the state, including the UTs without legislature. Overall, it is, if you see, with the state's contribution from their own fund subsequently for the other schemes, state-run schemes, it almost 36% is by the central government. And we talk of centrally sponsored schemes. That's a huge amount. And this does not include the centrally sponsored schemes like AIMS and all 29 AIMS which are coming up and other certain institutions. So thus, as such, indubitably, if you say health is an inseparable part of right to life in India, and the same has been very well acknowledged and worked upon by the government of India through various initiatives, guidelines, policies, and of course, legislation wherever needed, like even COTPA and all. So certain legislation are required for tobacco cessation and also for the other initiatives as such. So just to, I would like to repeat here that what we need is effective implementation with efficient utilization of funds, involvement of people at all levels with it. And I would like to, again refer to Dr. B.S. Garg sir, is that what have you done for the poor in the country as by the father of our nation. So that is there that, the ask but not this thing, what you can do that we should look at and include this with the governance reforms overall and empowerment of communities. That's where they get fully involved. That is the rights-based approach, which I think we should be looking at rather than only a piece of legislation. And we feel very happy with that. So we should first look at strengthening this, involving community, utilize these funds which are available, and then we can talk about further about the right and all over there. Once again, thank you very much for the organizers, Sipher and Tobacco Control Center, Resource Center for Tobacco Control, and also all the participants for a patient listening. And thanks to organizers for invitation. And really very, very happy to, be here, be a part of this. And very interesting and illuminating talks by Dr. Sonu Goel and by Director Vallabhbhai Patel Institute. And thank you very much. Thank you.
Well, thank you, Dr. Kotwal. First of all, I must thank you for accepting the invitation as a chief guest. And then I must also thank you for summarizing what has been said by the earlier speakers. So you said about, Dr. Sonu said that there's no provision in the Constitution to provide health as a fundamental right. And you also talked about the legislation in 2023 in Rajasthan, but our health systems may not be ready for it as yet. You talked about SDGs, Article 21, and then you talked about the direct principles, 33, 34, 39, 46. So it was wonderful listening to you, sir. And we'll have a recording of this, and we'll like to listen you again and again. And many people, they have asked for the recording. So thanks a lot, sir. Thank you. So over to Rajiv. So Rajiv, I think Dr. Kotwal has already made your life easier. So you don't have to provide concluding remarks. You can just propose a vote of thanks, please. I think Rajiv is not there. So Verma sir, you can do it.
Rajiv is there. Rajiv is there. Rajiv, you're mute.
I think either he's not able to hear. That's the problem.
Rajiv?
It doesn't matter. Verma sir, you can do it.
No, he's there. He's
Yes, sir. Sir, sorry. Actually, I'm not able to unmute myself, maybe from the host side, but now I'm audible, sir.
Yeah.
Yeah. So thank you for giving me opportunity to propose vote of thanks. I, Rajiv Chaudhary, on behalf of Sipher, a Resource Center for Tobacco Control, and Eco India, extend my heartiest vote of thanks to all present here. We are grateful to our chief guest, Major General Professor Atul Kotwal, sir, Executive Director, National Health System Resource Center, Ministry of Health and Family Welfare, Government of India, for gracing us with his presence and sharing a valuable insights on the occasion of celebrating World Health Day 2024. Thank you, sir, and thank you for summarizing the key points of all the presentations today. We also extend our gratitude to our guest of honor, Dr. B.S. Garg, Director, Dr. Sushila Nair, School of Public Health, Secretary, Kasturba Health Society, Mahatma Gandhi Institute of Medical Science, Bardha, Maharashtra, for his enlightening remarks on the theme of our webinar today. We appreciate Professor Dr. Sonu Goyal, sir, Director, Resource Center for Tobacco Control, Department of Community Medicine, PGIMER, Chandigarh, for highlighting the insight into healthcare as a human right and shedding light on the broader context of health need as a mandate by WHO and as per the Indian constitutions. Thank you, sir, for your detailed presentation. Additionally, we appreciate Professor Dr. Rajkumar, Director, Vallabhbhai Patel Chess Institute, Delhi, for his valuable presentation regarding importance of tobacco cessation in managing TB and NCD's disease. Dr. Kumar emphasized that smoking is the key risk factor for TB and also highlighting how smoking affects other health issues also. So, sir also mentioned that tobacco cessation is very important part to improve good health. Thank you, sir, for your detailed presentations. Dear friends and professionals, as an event like this requires meticulous planning and attentions, I want to express my gratitude and congratulations to our organizing team led by Dr. Rakesh Gupta, sir, Mr. Arun Verma, sir, from Sipher, and Dr. Sanchita Gupta from Eco India. Their dedication ensured the success of this particular webinar. Lastly, I would like to thank all the participants who are actively engaged in this particular webinar. We hope that information and perspective shared today will contribute in raising awareness on the theme of World Health Day 2024. So thank you, everyone. Have a nice day.
So thank you all. Thank you. Thank you all. Thank you.